Hello, we're going to talk about postoperative fever here as far as atelectasis and pneumonia. And when you have postoperative fever, with the exception of the first 24 hours where you can have a normal fever for a short period of time, but when you have postoperative fever, this is going to be the first one that can come up. So I kind of divided these up into the onset when they come on post-operatively. So atelectasis and pneumonia tend to come on post-operative 24 hours after, up to post-operative day 3. The UTIs tend to come on 3 to 5 days after. The DVT or pulmonary embolism tends to come on 4 to 8 days after. Wound infections tend to come on 5 to 7 days after, and then fever from drugs can come on any time. This is just a rough guide, so don't take this as canon, but this can help you sort of remember when these things have a tendency to show up. But atelectasis and pneumonia are certainly something that has a tendency to come up right away after an operation. So we're going to talk about postoperative atelectasis as well as postoperative pneumonia, and then I'll also give you a few clinical strategies to use in real life that can help you reduce the risk of this happening in your patients. So vignette, on your morning rounds, you visit your patient, a 52-year-old male who's on postoperative day 2 for an open cholecystectomy. He's alert and in no apparent distress and has no complaints. He tells you he's been mostly sleeping since the surgery. He slept well overnight and had no acute issues. Vitals, BP 130/80, heart rate 102, respiratory rate 19, temperature 100.9. Physical exam is significant for a 4 centimeter surgical incision over the right upper quadrant, which is clean and well dressed. Rales and wheezes are noted in the left lower lung field. His pain is controlled on dilaudid PCA, which he says he's used as frequently as possible. What is the most likely diagnosis? Of course, any patient who has a postoperative fever, you're going to want to make sure that you're looking into a lot of things, but you should know your most likely diagnosis based on the symptoms, the physical, and how far you are removed from the operation. And the answer here is postoperative atelectasis is the most likely diagnosis. However, pneumonia is certainly possible and should be on our differential. So some of the things that make us think atelectasis, of course, are the rales and wheezes that are noted in the left lower lung field, and also the tachycardia and the elevated respiratory rate, and then, of course, the fever, which makes us think this to begin with. But some of the other things that can put you at greater risk for these respiratory complications after surgery are where you have your surgery. So obviously if you have a cardiothoracic surgery or an abdominal surgery, that's going to cause you pain when you're breathing. When your diaphragm expands, your lung cavity expands to breathe, it's going to trigger the pain, say as compared to if you had surgery on your thigh or on your arm. So abdominal or thoracic surgery itself is a risk factor. The fact that this guy is over the age of 50 is a risk factor. The fact that this is postoperative day 2 makes it more likely that this is going to be a wind complication. Remember, wind, water, walking, wound, and wonder drugs. And then also the fact that he's been sleeping a lot since the surgery. We're going to talk about ways to prevent atelectasis and pneumonia, and one of those is chest physiotherapy and incentive spirometry. Certainly you shouldn't be sleeping all the time after the surgery. Maybe a really nice hospital bed, but you shouldn't be doing that. And then, yes, he's had pain, and certainly he should get pain management, but he's been using this as frequently as possible, and that's probably not a good thing. So postoperative atelectasis and possibly pneumonia. So postoperative atelectasis. We're basically just talking about atelectasis here. This is just atelectasis in the postoperative environment. So atelectasis is a collapse of alveoli. It is not an infection. So not only do you need to know what atelectasis is, you need to know what it's not. And it's not an infection. You're never going to use antibiotics for atelectasis. So there's an increased incidence of atelectasis in patients who are post-surgical because they have a tendency to hypoventilate. And by hypoventilating, I don't necessarily mean that they're not getting enough oxygen or that they're not breathing at a high enough rate. What I mean is that they're not filling up all of their lungs. And that's due either to general anesthesia, or it can be due to decreased diaphragmatic excursion, which is, in other words, just not filling your lungs up fully enough from surgical site pain. And this guy has a cholecystectomy, and so his incision is going to be right underneath his diaphragm, and all that pain is going to be close to the diaphragm and liver and up there. So you can imagine that he's probably got some pain on breathing. And I can tell you from personal experience, I've had a laparoscopic appendectomy, and I even had pain from that, and that's way down at the waistline. So any kind of abdominal or certainly cardiothoracic surgery is going to result in some pain with breathing. This is most probably the cause of postoperative fever in that 24 to 48 hour period. And it can occur without fever, so you can get atelectasis without fever, but most of the time when atelectasis occurs without fever, it's not clinically significant. And there's really no way to be able to tell, other than maybe your physical exam, but even in that instance, you probably won't be able to notice it. So this is most probably the cause of post-op fever in the 24 to 48 hour period, 1 to 2 days post-op. The symptoms are going to be fever most of the time. Sometimes you don't have fever, even though you do have radiographic atelectasis. And then also tachypnea and tachycardia. And I would define tachypnea as really anything over, I know the technical definition is like 12 to 20, but how many people really ventilate at 20 respirations per minute? Very few. So any patient that's ventilating more than 18 respirations per minute, I would consider that to be tachypnea, especially in the presence of tachycardia. Physical exam, decreased breath sounds on auscultation can be noticed just due to the fact that you're not inflating those alveoli, as well as dullness to percussion over the affected areas, and you can also hear some adventitious breath sounds. Chest X-ray would show opacity over the affected area, compensatory translucency, so you're going to have an opacity over the area that has atelectasis, and then as a compensation for that, you're going to have clearer fields, more translucent fields elsewhere. An ipsilateral hemidiaphragmatic elevation on the side that has atelectasis, as well as hilar deviation towards the side of atelectasis. And those two signs become more apparent when you have more severe atelectasis. So atelectasis itself is not harmful, but it can be an ominous sign. So we don't necessarily need to treat the atelectasis directly. We are going to address it, but we're not necessarily treating the atelectasis directly. The major issue with postoperative atelectasis is that it's often a precursor, like I said, that ominous sign pointing towards possible development of postoperative pneumonia. And what's the reason for this? With atelectasis, you get a fluid buildup, and a fluid buildup, especially in the lower lung area, and that basal lung area, is prime breeding ground for pneumonia. So postoperative pneumonia is the major differential diagnosis, and it should certainly be suspected if the fever persists beyond that second and certainly into that third or fourth day. What do we do to treat, and I mean treat in quotes, to treat atelectasis? What we want to do is we want to make sure that the patient is breathing properly, that they're ventilating and getting oxygen to the lower parts of their lungs, because that's where atelectasis tends to happen. So yes, we want to make sure that they're on adequate pain control, but what we really do mean here is adequate, not over the top, because if it's over the top, it's going to sedate them, and they're not going to be breathing they're going to be respiratory depressed. They're not going to be breathing in as deeply as they should. And if it's not enough pain control, then they're not going to be breathing deeply because it hurts. So we want to make sure it's adequate, proper pain control. Another thing, this is going to be your friend, incentive spirometry. I've got a picture of what an incentive spirometer looks like. And this is one of the most important things you can have for your patients because it allows them, gives them this little ball that goes in their meter, and it helps them make sure that they're in the appropriate range of ventilation. I'll show you what it looks like. And then chest physiotherapy can be done by a respiratory therapist. Certainly, you should always be very vigilant for pneumonia. Incentive spirometry is indicated for absolutely everybody who has undergone thoracic or abdominal surgery, and this is done as a prophylaxis for atelectasis. So indeed, we're actually preventing the thing that causes the pneumonia. So incentive spirometry for everybody who's had abdominal or thoracic surgery. So here's atelectasis, and not sure if you can see where it is here, but it's in the right lower lung field, right here. And you can see a little bit of elevation of the right diaphragm, and you can see also that the mediastinum is displaced towards the right. Notice how you've got your right heart border almost in the middle of your right lung field, and your left heart border is normally would be down here. So you've got a rightward medial displacement of the mediastinum. Okay, here's another one. This is atelectasis on the left side. So here again we have atelectasis up here and possibly down here, but you've got the opposite here. So you've got displacement of the mediastinum to the left. Hilar displacement to the left. You can't really see the diaphragmatic borders, but you can see that you've got that compensatory translucency. And then here's another one. This one's in the right upper lung field. And again, you've got a little bit of diaphragmatic movement here, and then your cardiac silhouette is right on the midline, which it shouldn't be. Normally the cardiac silhouette is kind of more on the left side. So there you go. Those are your findings in atelectasis. All right, postoperative pneumonia. So this pneumonia is an infection of lung parenchyma, as you probably know. It is a complication of atelectasis when it occurs. So, I mean, it's not always a complication of atelectasis, but when you have postoperative pneumonia, it is a complication of atelectasis, and that's if it's not detected or if it's not adequately addressed. So remember I said that you can have atelectasis without a fever? There you go. You can get postoperative pneumonia without having detected the atelectasis, and usually it's the fever that helps us detect the atelectasis, or the lung sounds, but we don't always hear those. So you can get postoperative pneumonia without having a documented history of atelectasis. So this is a complication of atelectasis if it's not detected or adequately addressed. Pulmonary complications are the #1 cause of postoperative morbidity and mortality, and it's the #3 most common cause of postoperative complications behind the surgical site, wound infections, and the urinary tract infection. So these are very common. The correct implementation of standard postoperative care, read your incentive spirometer, reduces the risk of postoperative pneumonia. So you want to make sure that those patients are breathing and ventilating as best as they can after their surgery. And some patients are going to be able to better than others. Use your common sense, but all patients should have an incentive spirometer by their bedside. Symptoms are going to be dependent, of course, on severity, fever, tachycardia, or possibly bradycardia, of course, if they're more advanced. And tachypnea are common. Altered mental status and cyanosis occur, and bradycardia occur in the more severe circumstances of postoperative pneumonia. Physical exam, you'll note rales, rhonchi, and wheezing, what we call our adventitious lung sounds. You'll also hear a decreased intensity of breath sounds, egophony, which if you have the patient say E, when you listen over the affected area, you'll hear it in your stethoscope. You'll hear it come out as an A, and that's due to the edematous area where you have the pneumonia. And then dullness to percussion. Those are what you'd see on physical exam. So as far as diagnosis, the chest x-ray is the best initial test. Sputum culture is more specific, and you certainly have to get it, but the chest x-ray is your best initial test. Your sputum culture is certainly more specific and is going to get you what your, most of the time going to get you what your causative bacteria is. The causative bacteria for postoperative pneumonia primarily are the same as your other hospital-acquired pneumonias, ventilator-acquired pneumonias. However, it's not always possible to get a conclusive result on your sputum culture, and that's simply because the value of the sputum culture is dependent on whether it's attained properly. CBC and ABGs should also be obtained on patients who've been diagnosed with postoperative pneumonia, but your chest x-ray is your best initial test. Important to remember here, I kind of alluded to it earlier, postoperative pneumonia is not a community-acquired pneumonia. It is a hospital-acquired pneumonia, or in some cases, a ventilator-acquired pneumonia. Either way, that means you're going to be treating this type of pneumonia differently because there are a couple, in particular, bugs that we're very concerned about, that we wouldn't be concerned about in a patient that just, let's say, came into the ER with pneumonia. So here's a chest x-ray showing pneumonia. This is a lobar pneumonia, right middle lobe. Here's another one. And here's another one. Okay, so remember your basic microbiology. Most common cause of pneumonia is always strep pneumoniae, regardless of who the patient is, what their immune status is, whether or not they have sickle cell disease, etc., etc., etc. None of that matters. The most common cause of pneumonia is always strep pneumoniae. Hospital-acquired pathogens notably include Pseudomonas and MRSA, and so we need to be concerned about these bugs when we're treating a patient with postoperative pneumonia because it's possible that this is the cause. And since we're not going to be getting our culture until a couple days later, if at all, if we get a good culture at all, we need to make sure that we're covering these bugs. So technically, the empiric therapy is going to be based on the patient's risk for the multi-drug resistant infection, so the Pseudomonas and MRSA. So technically, you are not necessarily covering these, and I'm saying this in the hospital setting. I'm not saying this for the USMLE. So you may see your attendings doing things that aren't necessarily what you're going to do on the USMLE. So if you have a young, healthy patient who hasn't been hospitalized very long, you probably don't need to treat them for Pseudomonas and MRSA. And there's that whole thing about increasing resistance on the part of some of these bugs, and that's a legitimate concern. But for the USMLE, if you have a patient who's got postoperative pneumonia, who acquired their pneumonia in the hospital, you need to cover them for Pseudomonas and MRSA unless the sputum culture tells you otherwise, because this is a hospital-acquired pneumonia. Of course, if they have those risk factors for the multi-drug resistant infections, Pseudomonas and MRSA being poorer health, immunocompromised, hospitalized for more than 5 days, recent antibiotic use, and there's a few more, then that's all the more reason to treat them for potential Pseudomonas and or MRSA. But for the USMLE, I would always assume that with a hospital-acquired pneumonia, you need to cover those bugs. So the empiric treatment would include one anti-pseudomonal, and you can use the anti-pseudomonal cephalosporins, which would be ceftazidime or cefepime. You can use piperacillin tazobactam or ticarcillin clavulanate. You can use tobramycin, amikacin, imipenem, or meropenem. Those are a laundry list of the drugs that are active against Pseudomonas. And then you should also use one anti-MRSA drug, which vancomycin and linezolid are the most common ones that you see used. And using these drugs, using a regimen of these drugs would cover your garden variety pneumonias like strep pneumonia, etc. Also, I'm just going to, as a side here, I just want to note on the x-rays you should always also be looking for cavitation, possibly aspired pneumonia, aspiration pneumonia. That's another possible cause of pneumonia, but usually the surgeon or the anesthesiologist will have noted that something like that had happened during the surgery. But just something to be aware of since we're talking about postoperative pneumonia. Risk stratification systems are good to keep in mind for any kind of surgical patient, particularly in postoperative pneumonia, because this is going to help you remember what the patient's risk is to developing postoperative pneumonia. So remember, I was saying, some clinicians don't always go by the rules that you follow on the USMLE, and this is kind of why. So some patients don't fit these rules. Obviously, if they do, you've got to be more concerned. So if the patient has been or is on mechanical ventilation, their odds ratio of developing a severe multi-drug resistant postoperative pneumonia goes up 70-fold, and that makes sense because they're still on the ventilator. If they're in the ICU for more than 5 days, goes up 72-fold. If they're on a tracheostomy, 95-fold. So these three things make sense because remember, what are we considering? We're considering hospital-acquired pneumonia, meaning being in the ICU or being in the hospital, and ventilator-associated pneumonia, meaning tracheostomy or mechanical ventilation. So that's why they do that. But for the USMLE, remember, please remember, postoperative pneumonia, be concerned about MRSA or your Pseudomonas until you get your definitive culture result back. And then these are some of the other things that can put you at risk for postoperative pneumonia. Okay, and let me just say, I put that on here, but don't memorize this. Just kind of have an idea of what some of the risk factors are. Some clinical strategies. So for all patients who have gotten abdominal or cardiothoracic surgery, you're going to want to make sure that they've got an incentive spirometer by their bedside. This is so important. Most hospitals now are aware of this, but some aren't. So if you have a patient that's postoperative, I'm not talking about foot surgery, I'm talking about any kind of abdominal or thoracic surgery, and they don't have their incentive spirometer by their bed, you need to tell them they need one, and you can just tell a nurse. This isn't something, if you're a medical student, you don't need to be an MD to order this. Just tell the nurse to get them an incentive spirometer. Adequate pain control also is going to be important as well, and that's, I mean here adequate. I don't mean too much, I don't mean too little. Remember, too much is going to respiratory depress them, too little is going to make it painful for them to breathe. Both of those will lead to atelectasis. Adequate pain control. Enough so that when they're using their incentive spirometer, they can get that ball in between these two lines here. That's what's telling you that you're ventilating properly. A couple other things, 30-degree elevation of the bed is good to help the patient get their mucus out. Non-invasive positive pressure ventilation can be useful for some of the higher risk patients, certainly not for all patients. Weaning and sedation protocols, so kind of goes back to this patient who is on his Dilaudid PCA. He was taking it every 4 hours or every 6 hours, whatever it was set to. Probably didn't need to take it that often. So you should be trying to wean the patient off of their pain medication as quickly as you can. But, keep it in mind that they need to be able to have adequate pain control. And then chest physiotherapy, this can be done by a respiratory therapist. I don't know what they do. Sometimes we order them though, particularly for the patients who have atelectasis. So these ones in yellow here, you need to know about and remember. the rest of these are good to know. And that's it.